platelet count now. So most of the time we ask for a platelet count, and the lab also gives a platelet count. And suddenly one call per day, 100% I can rely upon this because one of the counts would have been only 13,000. And the clinician calls that, please do a manual count. Do you accept this or how will you tackle this? Platelet count are best on manual count. So they always say this, doctor, did you do a manual count? That's the best way. So what do you feel whether we can go ahead and truly say that, yes, manual counts are the best, or you say that automated counts are best? That's the question. The second is that, do you consider that platelet count can be taken as an inflammatory mark? So these are for you.
So coming to the first question, I would say in my practice when I started around 2017, I was more relying on manual counts than the machine counts because machines which we had and the advancements which are now was not available at that time. So around that time, there are many instances in which the machine count won't be correlated, and the smears, when I see there will be giant platelets, there will be clumps which won't be actually picked up by the analyzers. But right now, many advances have come, and the analyzers themselves have been well fine tuned to give an actual correct count in most instances. Having said that, there are again certain low end analyzers which tend to give a very falsely low count, specifically when I with respect to giant platelets. So I would say platelet counts right now are best reported in analyzers, but definitely low counts have to be verified based on your smear review criteria of your particular lab to rule out pseudothrombocytopenia, maybe due to clumps or in case sometimes large platelets or platelet satellitism and so on. For the second question, yes, I am seeing a lot of cases, definitely in sepsis, wherein platelet count are coming high. The other well-known instance is treatment of iron deficiency anemia as a response to increasing hemoglobin. Platelets also tend to increase. So those are my views. Sena sir, do you have anything else to add?
That's good, doctor. You are reinstating that the platelet counts are best from the analyzers if the QCs have been through, and we have to rely upon that. And most important point, what you brought out is right, the pseudothrombocytopenia, which we encounter with the clumps, what we are seeing. And if there are many, then the collection should be tackled. And if you have EDTA associated pseudothrombocytopenia, then one has to go collect it with that of the citrate tube, and then you have to analyze the platelet count so that you'll be able to give. Suppose you don't have accessibility to the citrate or a patient, I think a smear review, as you told, will be able to give us whether this is having a clumping of the platelets itself. That's beautifully explained. That's great.